Okay.
We're going to get started here. Welcome. I'm excited to be in person, and excited to see all your faces. So welcome. First thing on the agenda is approval of the minutes from 2/18, February 18th. A motion to approve.
So moved.
Thank you. Do I have a second?
Second.
Thank you. All those in favor signify by aye.
Aye.
Any opposed? Okay. All right. Next up is Justin. He's going to give us an update on accreditation. Thanks, Justin.
Sure. Hello, everybody. There's an echo. So as far as accreditation goes, I think, well, if we remember about 6 years ago in January of 2020, we had received a no accredited status. There were a lot of practices and things that we had learned at the time. There's been improvements in some areas. We've gone through policies and included parts of like diversity, equity, and inclusion, more efforts around those, implemented the first-time plans of like health assessments, improvement plans, strategic plans, quality improvement, and implementing processes around that. Those have been really beneficial. As far as going forward, there at this time are no plans for seeking accreditation again. There haven't necessarily been resources that have been identified from having accredited status. So we've taken the good pieces that have been applicable, and there's been some areas that haven't necessarily benefited local public health as much as they benefit state public health departments. So that's sort of where we're at now. So now it's a matter of just making practices continual and integrating them deeper into the agency.
I have some questions, but anybody else have questions first?
I have a question.
Okay.
So, Justin, are there any other public health agencies in North Dakota and/or Clay County that have sought this accreditation?
As far as I know, Stutzman County at one point, they were accredited. They jumped on right when FAB was in its original beta version. And I spoke to one of their staff who was their accreditation specialist over there. It changed significantly by the time we got to the 1.5 version, which is what we were under. There were a lot of added sections that they didn't necessarily require first time around. And then since then, I think there's been discussions as well as changing, because the dynamics between a state health department and a local public health department can be so different as far as communication goes between them, and what requirements are, like surveillance systems and how that operates. It's very, very different. So, even looking at like South Dakota or Minnesota, where they work in step with state health department, is very different from the way that we work with the North Dakota Health Department. I don't know about Clay County. I don't believe that they were seeking it. Stutzman County, I know they didn't seek reaccreditation. The state health department is accredited, and they are going through reaccreditation right now. And I believe there is one other, I think Grand Forks is going through it. I don't know if I'm supposed to spoil that or not. But Grand Forks is going for accreditation at this point. And we've been down there, Desi and I went down there and helped them with a little bit. And I think they have a really good shot at it.
I have a couple.
Okay.
Thank you so much, Justin. I just was wondering, so achieving accreditation status wouldn't have made a positive impact of finances at all through increased reimbursement or anything like that?
No, there's no further access to grants because you have accredited status. Not that we've seen, and I haven't heard anything about that going forward. If there is going to be a change, I know that, well, at the time, I should say, the state of Ohio was requiring all local public health to be accredited. But as far as I know, that was the only state that was requiring for local public health. It's a costly event to go through. So as it's gone up now to, and I'm sure with inflation, everything else has gone up too. I'm not sure what it costs for it, but it's significant to overcome right now with local public health.
Okay, I can see if there's not an obvious cost benefit. there, I can see that decision, that impacting the decision. So knowing that accreditation really facilitates that continual improvement, is there still a way to monitor standard updates in order to really drive that strategic plan?
Yeah, well, and Des, you'll get to it later in the agenda too, but one of the parts that, I think Fargo Cast has really benefited from this is we have developed plans again for the first time, and now it's just a matter of continually reporting on them, and that involves like staff involvement and management involvement, and then we go back to the Board of Health for any reporting that we do, so.
Perfect, thank you. You'll always take something from those processes, even if, you don't ultimately achieve it, so.
Absolutely. There's been a lot of policies that we've made adjustments to that they're much better, have it in writing and things that we haven't seen, especially with DEI. And, but then of course there were some areas where we started to make a list of like new hire orientation stuff that we were like, does this benefit anybody? And I was like, no, that was just a hoop we jumped through before.
Mm-hmm. Okay, thank you.
Other questions? Okay, Justin, you had indicated that the state is accredited and, maybe one other local agency, and that there's a difference between kind of state versus local and how our state operates. Do you think there's any plans within that accrediting organization to do something different for local versus state, if that's where we see most of the issues being, or?
Yeah, and the hard part, so we had a accreditation specialist she's out of Virginia, Britton was her name, and she was wonderful to work with. She was super helpful. And we had talked at the time about, because with the southeast counties that we all work together with Richland, Sargent, Steel Trail, Ransom, like accreditation for them just does not exist. Like there's no opportunity for them to do some things because they don't have like community-based programs like we do. So they rely a lot on state health departments. So FAB at the time had been working on a program that would be more just quality improvement focused. So it would be like accreditation light. And that would have been an opportunity. I don't know where that went to. Obviously with the pandemic, everything kind of got flipped up in the air. We do know, as again, from like our visit, they had never done virtual site visits, which they had to adapt to. So we were a good training ground for them with that. But as far as new programs that would be focused for other health departments that would be just quality improvement would be helpful, and honestly would probably lower the cost barrier as well. So I haven't heard anything further from that.
Okay. Well, I think certainly something to watch, as Lynn probably knows. There's a lot of different accrediting bodies and many aspects of healthcare that do different modules depending on, what you want to be accredited for versus
Right.
kind of broad accreditation. So something to keep an eye on. Okay.
Okay,
Thanks, Justin.
thank you.
All right. Next, Desi on strategic planning.
Yeah, welcome, you guys. This seems very far away, but so our strategic planning process should be, we've actually done the initial email kickoff for all of our staff. We have secured a contract with 2 public health consultants. One is based in Kansas and one is based in North Carolina. The gentleman from North Carolina is actually someone who was on our accreditation team for FAB, and so he's no longer working with them. The female is the one who did strategic planning for Grand Forks Public Health, and so both have really, really good public health experience, and so we're really looking forward to that. The plan is to do some virtual work, some information gathering with staff. They are going to actually come on site June 7th and work with our management team one-on-one, doing some cohesion things, doing some, how we can improve as a team. And then on Friday, the June 10th, they will be doing our strategic session, which will involve large group management and then an equal portion of staff. And then that will be a 9 to 4 workday, and from that, we will hopefully come up with our initial plan, which will then be put out to all of you and to staff for final feedback and suggestions. But we're really excited about it. It's been, I was talking with Arlette, and I can't remember the last time we did strategic planning. It's been several leaders ago, and it really felt more like a business model, not specific, to public health. So really looking forward to looking at what we're currently doing within the agency, what our community needs are, and kind of how we fit in with that.
Excellent. Questions for Desi? Is there anything that you need from us during the planning phase of that? So while they're doing the work with your internal staff, is there any support that you need from us, or?
There may be an opportunity. I know we talked about, community partners and different things, if they're going to do some information gathering. I don't know their whole routine, and so once I find that out, I can share that with the group.
I think there'd be some of us that would be interested in helping in that process. So, okay. Excellent. Thanks, Desi. All right. Do you want to talk through the budget meeting?
Yeah, I actually have all the rest of them, so.
Okay.
I'll just keep going. So we typically have a budget meeting scheduled in May, but the last few years, due to the city timing and the process, it really is, it's so sped up this year that there isn't going to be a point to have a budget meeting in May. We actually had to turn in our budget template April 1st. They wanted to get that initial one submitted before Kent Costin retired, so we've submitted that. Our PEC requests are due by the end of today. So we just thought later in the agenda, we'll talk about, the budget and where we're at, and if you have some questions, but we really didn't feel dedicating an entire meeting to it would be worthwhile for the board.
What does PEC stand
Oh,
for?
Position Evaluation Committee. So when we're asking to reclass or we're asking for new positions, anything to support.
Okay. Questions for Desi in the budget piece? I know, Melissa, you're going to walk through that later, so. Great.
And then the organizational structure, Chelsea had asked about if we knew anything about the merger between DHS and the Department of Health at the state level and how that might impact us. And so you have in your packets the proposed organizational chart that will be effective this month. That is really the extent of what we know. So they're anticipating everything should be the same. They're saying billing and payment and all of that should not be impacted at our level, but we're not certain that that may be the case. So I think there is a lot of uncertainty with state staff as well, but really we haven't heard much of anything as far as, how this is going to interface with local public health.
Okay. And I don't think we have the org chart in our packets, but I'm sure we can get it
It's not in your
afterwards.
packets, but we will send it out.
Okay, perfect. And, from my understanding, this isn't unique. A lot of states have combined Department of Human Services and Department of Health, Department of Health and Human Services. So seems like there could be some efficiencies gained by combining the two. So I'll be interested to see how this evolves. But does anybody else have any questions on that topic?
And the last one was just, it was oversight on my part. Breton and I had talked about him doing an update on STIs at the next board meeting, and I had forgotten about that when we did the agenda. So we will be adding his topic on.
Okay, excellent. Okay, next I think we have, is he gonna go next or at the end?
Yeah, we'll have Dr. Severson
Okay.
start us off.
Perfect. Welcome.
Is it under the PowerPoint? Okay. Hi, I'm Grant Severson. I'm a pediatrician in Fargo. I was asked to discuss health misinformation and disinformation. This comes from a presentation I did at the city council meeting a month ago. I'm a big fan of cartoons in all forms, so there's a lot of good political cartoons discussing misinformation and disinformation, both currently and in the past. So I thought this is a good way to start, which certainly did feel like, during the pandemic that we had the four horsemen of the apocalypse and, lots of other things. So the reason I got interested in this was the Surgeon General within the last few years really came out with a policy statement discussing that health misinformation, not just with COVID, is really becoming a serious threat to public health, primarily because many different reasons, but exemplified one very nicely for us during the COVID pandemic. But really, it undermines public health and their role in society, and it also provides just parents and caregivers and just everybody, a lot of just poor information that really impacts health decision making. This is from 1808, talking about Edward Jenner, and the original anti-vaxxers, just discussing about how he vaccinating against smallpox was going to kill a bunch of people, and just how this is not something that's new in the world. This is a couple other cartoons. The one on the right, obviously, is from the 1983, discussing the AIDS pandemic and the misinformation that came along with that. And obviously that impacted, many different populations, but it certainly put a negative spin on what HIV/AIDS was, and it certainly impacted who was treated, how they were treated, how it was funded. And this is just that masking is not a new controversy either. This is from 1918 with the Spanish flu. If you look back at the things that we went through with vaccination and with quarantine and with masking, it mirrors exactly what happened in the 1918 flu pandemic as well. I mean, there was still a lot of people that were pro-mask, anti-mask. Obviously, we didn't have social media back then, but so the public got a lot of their input from the papers. But it's certainly something that public health has had consistent themes for a long time. So I like that picture. So the Office of the Surgeon General has a lot of good information about health misinformation, and one thing they have is a community toolkit. And really, it just kind of discussing what these different topics are. Misinformation is false information shared by people who do not intend to mislead others, whereas disinformation is intentional spread for a malicious purpose to either trick someone into believing something for financial gain or its political advantage. There's a group of people called the Misinformation Dozen. I don't know how familiar you guys are with them, but there's a lot of information about these 12 people that drive the majority of disinformation and misinformation on social media. So if you look that up, you can see they actually have some really good, I meant to put it in this presentation, but I forgot. But just talks about how much they make from all their social media, how many people are employed by them, and the different strategies they have. Misinformation is usually shared by people who don't know or can't recognize the claims are misleading or false. And most of the time, this is done out of a good place. They want to help other people. They want to address their questions. They want to rationalize there's a lot of conflicting evidence and seeking answers. The main reason we're having so much issue with misinformation is that we live in a society that's pounded with information from all different places, and we have an overabundance of facts, and we don't know which ones to trust and which ones we should trust. And it makes it hard for people to find good sources and reliable guidance. In particular, again, like with the pandemic, people feel anxious, depressed, overwhelmed, and they're just desperate for an answer that will provide them, some solace, but also will explain a very confusing world to them in a way that they can understand. And when especially nowadays with immediate answers being expected, and we don't have enough time really to deeply analyze all the different evidence that's out there. This is from the Kaiser Family Foundation, and it's a really, I have a couple graphs from there, and really it shows that about 80% of people believe or are unsure about at least one common falsehood about COVID-19 or the vaccine, which was pretty striking to me. And those are, exaggerating the number of deaths, pregnant women should not get the vaccine, deaths due to COVID vaccine being hidden by the government, COVID-19 vaccines are shown to cause infertility, ivermectin is safe, you can get COVID from the vaccine, COVID vaccine contains a microchip, and that COVID vaccines can change your DNA. And so the fact that, well, all of us have probably heard many of these, but that we're not sure or that we don't know if they're true, the number of people who feel that way is pretty striking. It does tend to depend upon where you get your information from. This doesn't include social media. It's primarily just looking at mainstream news sources. And you can see that, some news sources have, audiences that seem to believe less misinformation. I don't know, I'm assuming on some of them it's due to the quality of the content that they're including. Not all of them, I'm sure, but it does skew along those lines. And in addition, how many falsehoods you believe kind of depends upon, certain demographics of the individual, which, some of them are not unexpected. If you're unvaccinated, you tend to believe more false statements. I'm political in some ways, but looking at just political party ID, it does tend to skew more towards Democrats tend to believe less false statements. Now they still believe about 1 to 3 false statements, which is a big amount considering what those false statements are. And then where you live kind of impacts it a little bit. The fact that if you're a college graduate or not didn't impact it as much as I thought it would, which is very interesting. And then age. Again, we tend to think of the elderly population. They were watching a lot of Fox News or MSNBC or whatever, where they really get skewed on their information silos. But still, not as much difference as I would have expected. So there's still a lot of misinformation out there. So again, why is it tempting to share this? And again, it's because we feel that we have new information that others don't know. So we feel special, or that we just really found something aha that other people don't have. We want to protect the people we care about, and so we want our kids to be safe. You see that in a lot of vaccine hesitancy. Parents have a hard time saying, "Oh, I want to give this to my kid because what if it does something to them?" As a pediatrician, we see that a lot, but it's something that became even more apparent. We're seeking explanations or wanting to share information that helps us make sense of events. So things that make sense to us that seem to fit our worldview. We want to feel connected to others, and that's really where social media gets into play, because these different social media groups, for a lot of them have algorithms that tend to, once you start to access one information item, it tends to send you more of a similar information item towards you. And so you can really get skewed and put down, rabbit holes and things like that. There was a good New York Times series about rabbit holes about a year ago. But really, information silos is another term for that. There are people out there, they break this down into 7 different types of people. So you have creators on the left, and then sharers on the right. And there are people that are intentionally causing disinformation for gain. There are people that do it because they are mischief makers. There are people that make hoaxes, sometimes they make money. People that are enthusiastic because they're in support of someone who is presenting the information. There are people that are true believers, that they're just deeply connected to their online community and it's part of their identity. And I think we see that a lot with people that are very rigid in how they feel about information, where they're not willing to pull back or to really take in new information because it's just so wrapped up in who they are. Overshares, people just like to share, and then casual shares, just, probably a lot of us where we're just on Facebook randomly and we're like, oh, this looks interesting, I'm going to share that, and maybe we don't vet it as well as we should have. Some tactics. So if you look at websites, and I'll have an example of a website here in North Dakota, really trying to display something that's a non-healthcare related organization as healthcare related, having a professional looking website is important. And then including that you have secret information or inside knowledge, and then having people do like firsthand experiences where they have testimonials or things like that. Like I talked about, the sources, social media, websites that look official or professional, misused quotes, out-of-date data. One thing we really saw a lot during this pandemic were the cherry-picked statistics and misleading graphs and diagrams, because science is very complicated, and you can take a quote out of any paper and say, well, this is referenced here, and 90% of people are not going to research that paper or look at the source of where you're getting that information. Maybe more than 90%. I thought this was a good picture. I'm not a Packers fan. I lived in Wisconsin for 12 years. I really am not a Packers fan now, but Aaron Rodgers and Joe Rogan, you look at areas that we can get information. Obviously, Joe Rogan is a very popular podcast host, and he has a ton of followers, and the things he says and the people he brings on his show influence other people. And Aaron Rodgers, obviously the same way, very popular. To me, it's scary that a person who is looked up to by so many kids, not just in Wisconsin, but across the country, is, willing to lie and, not, be willing to do something for the good of the community. But anyway, I thought that was a funny picture too. This is the website I was discussing. It's a Midwest Public Health Coalition. Couple things. The website itself is not super professional. A lot of the links don't work. And you can see there's a lot of overlap in words and stuff like that. But one thing in particular, they have a red cross on here. The fact that they say public health within the name, if you know about public health and you look up Midwest Public Health Coalition, I think anybody initially would assume this is a reputable organization, right? Importantly, if you look at the people that make up this coalition, and they've had talks around the state, even into western Minnesota, no one in the coalition actually has public health experience. There are people that are PhDs that are within the organization, but in biochemistry. And, it is something that anytime you're looking at public health, you're not usually seeing a contribute button on the website. At least I don't think Fargo has it on their public health website. No, okay. You can see this. One thing that's interesting is the founder is not from North Dakota. He actually has a sister organization in Wisconsin. And so he has done this in similar states for different reasons. But you can see they have pictures of doing lectures at Grand Forks City Hall. I know they're in Fargo. They're very active online. They have their own Facebook page. But the fact that they are asking for money generally is a red flag as far as I'm concerned when you're looking for good health information. This is a couple of their posters. Obviously very trying to get a lot of emotion out of people. Poisoning America's children, vaccine exemptions in you. The truth comes out, some of those leading statements where they kind of catch you and be like, oh, they know something secret that, the mainstream media or mainstream healthcare is keeping away from you because of profit or whatever nefarious reason you think we have. Sometimes misused quotes. This is a quote that was taken out of context and used as a part of a communication. And essentially what the person who used the quote said was there's a recommendation to wear surgical masks to supplement other public health measures did not reduce COVID-2 infection. And if you just took that part of the sentence, then you'd be like, oh yeah, that certainly seems to support that surgical masks are not helpful, at least in this study. But really, the conclusion was taken from a larger paragraph where the last half says by more than 50% of the community with modest infection rates. So they're talking about a threshold that it does prevent. It does prevent some, but maybe not by as much as we hoped, as well as using other kind of social distancing aspects. And this is the name of the paper that it came from. And really the goal wasn't to determine whether or not masks actually prevented COVID. It was how much they prevented COVID, because the theory was that they already did. Looking at health misinformation, this is something that, trying to teach the general population about is important. But did you check with the CDC or public health department? Now, I don't know how many people are going to do that. A lot of people don't trust the CDC or the public health department, especially if you're getting some of those skewed populations. But for myself, just for when I talk to other organizations, did you ask a credible healthcare professional? Doctors and nurses still have a good relationship with the vast majority of our patients, and they rely on us for good information. And so it's important that when we interact with people, we ask them what questions they have, and we try to address them in a way that's as helpful as possible. And then, easy things you can do as well. Look Google in the search engine to see if it's been verified. Look at the About Us page on the website to see if you can trust the source. And then if you're not sure, don't share. And that's kind of the biggest thing. And this is the last slide I have, talking about Big Bird. Oh, not the last one, I have one more after this. He also was into vaccines back in 1976. And so it's not something that is new for him, but I thought that was kind of cool to compare the two. And then, of course, it becomes political in that, people who are trying to get benefit from talking about misinformation or disinformation tend to politicize or make it, part of their spiel to, get votes and things like that. But anyway, that's all I got. Does anybody have any questions?
Questions? Thank you, Dr. Severson.
Thanks.
I am a Packers fan, so this was a disappointing year for me in many ways.
I'm sorry for you.
Yeah, me too. I just have two comments, and you can sit down. It's okay. I was surprised about the variation between age and location wasn't as much as I thought it would be. It really seemed to be focused on where we're consuming that information, which really means that no age or location is immune from it. And then just my comment on research, true scientific research, as physicians, very, very time-consuming, complex, and requires you to find conflicting information. You seek conflicting information so that you can do more investigation to really dig down. And it takes years and years to really do true research. And yet we had people, unqualified to really make these decisions and spread the information after looking at one source. So I think that's a challenge really to all of us to make sure that when no matter really what the topic is, that we check ourselves and look at other sources that we may not normally do, just to keep ourselves accountable for what we talk about.
Great.
And there's a couple different, so a lot of the social media sites have started to be better about as far as vetting health information, or at least labeling health information, particularly with COVID. One thing you can do as an individual is if you see something that's false or you believe it is false, you can flag that post on Facebook as health information. And you don't have to do any more vetting after that. They will actually go through, and I believe, go through every complaint and will determine whether or not the post is factual. And if it is, then they keep it up. If it's not, then they make you take it down. And if you have repeated episodes of spreading disinformation, you can have your page, or at least your ability to post taken away for a certain period of time, or even get a lifelong ban if it's persistent.
Excellent point. Any other questions?
Madam Chair, if I could, this presentation was preceded at the City Commission meeting with a number of different research projects that had been done and are in the process, actually. And it was really helpful. I think people, during a time when it's unsure where everything was going and people were worried, people were dying, getting sick, look for an immediate answer. And that's just not the way scientific research works. I mean, it takes time to figure out the best approach. And it was real evident from the research that was presented that, it's answers that evolve over time. And when we were in the middle of it, it's really tough to be able to respond on a timely basis to something that was happening immediately. So it was just a really good recap on the entire process and why we were seeing what we were seeing. And it was good.
Anything else?
Tracy?
I know I'm not the presenter. Can I make a comment to yours, Arlette? I just want to say, in addition to what you just said, another confusing part is that science will often change. And it appears that we're doing a 180. So a classic example in pediatrics, right? We used to tell my parents' generation's parents to have their babies sleep on their stomachs. And now we've completely done this huge public health campaign for back to sleep, right? Because the science changed. Another example is like food allergies. We used to say, don't give these certain foods before a year. Now we're really pushing right at 6 months, give them peanuts, so the science changes. And I think that too, it doesn't mean the original science was wrong. It just means we're doing the best we can, and we did further studies, we kept asking questions, and now the data's changed. And that played out throughout the pandemic in multiple ways. And I felt like it was used as a way to say you were wrong, or you didn't know what you were doing. And there's just a delicate distinction to make there. So.
Thank you. Yep, Charlene, you have a question,
Thank you.
statement?
Yeah, thanks. And I'm glad you said that the science is changing, because, a lot of what was called misinformation a year ago, now we know to be fact. The idea that we were told by the CDC that those who were vaccinated didn't carry a viral load, and now we know that's not true. We were told that the vaccine was a 100%, 99%, 98% effective, and now we know that that's not true. And so, and I think that Dr. Severson made it, a good comment when he said we kind of need to be a little bit humble about how we present some of these things, because some of what we're saying today is misinformation, might not be a few months from now. And I had to know, and I noticed as I was coming in, the big banner across the doorway of City Hall saying "Vax for all." Well, we now know the vaccine doesn't benefit other people; it just benefits those who are vaccinated. So that was just a little piece of misinformation that's still sitting on top of City Hall's doorway. And I guess I would like to say that. In order, we've seen studies that the CDC, for example, less than half of the people trust what's coming from the CDC. And I think part of that may be attributed to the fact that we don't have a whole lot of public debate and conversation once a supposedly trusted organization such as CDC comes out with a statement. There's no allowance for questioning or debating or talking about that information. And then when it's later proven to be perhaps, new studies, new information updates that information, I think we've kind of shut down some people's access to what might be truthful, helpful information. I'm just saying this because I think it's important that we have more open discussion and debate rather than, flagging, reporting, and shutting people down.
Any other?
I would just say that vaccination is inherently for all of us. It's not, certainly it can help the individual, but you don't vaccinate for yourself, you vaccinate for the community. And that's the reason that vaccines work, is because if you get to a certain threshold in the community, you're no longer having vaccine preventable illness. We're not there with a COVID vaccine yet because it's not as effective as we hope, but you can certainly see it with smallpox, varicella, diphtheria, tetanus. Those are all things that prove that vaccination is effective and helpful.
Madam Chair, if I could ask a question, either Dr. Newman or Dr. Severson, do you have a sense of how CDC digests the information, the research that's coming to them, and how they make the conclusions that they do? Understanding that it might look like it's all done in a closed room, but in fact, it's a very thorough process.
It depends what the topic is. Vaccinations in particular, it's a very transparent public process. There's something called the VRPAC, which is a subset of the FDA that meets, and they review, often heavily debate every piece of data or scientific trial that went into a certain vaccine. They look at effectiveness, they look at efficacy. They present that to the FDA. and then the FDA makes a recommendation. This just happened with boosters as a great example, and you could watch all of this publicly. And then from there, the FDA goes on to make a decision, and they advise the CDC, and then experts at the CDC make a decision. So it goes through multiple levels of analyzation and recommendation. I don't know if you have anything to add.
I mean, and that doesn't mean that it's perfect. And, certainly, as we've talked about several times, science does evolve. And, we wouldn't expect it to be the same forever. Otherwise, we'd be, treating different diseases the same we did 30 years ago. So.
Any other questions, comments? Because I know we have a few other topics to get to. Thank you, Dr. Severson. Appreciate that. Okay. Health officer update. Dr. Newman?
Okay, I thought Brenton was going to go first. Mine is unfortunately still mostly related to COVID, but we're pledging to do more vaccine stuff next time. I just wanted to update the board on a few things I'm following, and I'll keep you guys updated if there's big changes before August. When we meet again, but BA2, you've probably heard of, is a new sublineage of Omicron. It gets a little confusing. It's one of many, so there's also BA.1, BA1.1, there's BA.3, but BA2 seems to be playing out differently in various parts of the world. It's a little unclear how it will affect the US. The WHO has reported that the BA2 subvariant accounts for 86% of COVID-19 samples currently in the US that are being sequenced. So that's now that's worldwide, making it the dominant variant. Currently, BA2 accounts for about 72%, at least that was last week. We should get a new release today of US cases. And that's just noteworthy because it was up from 57% the previous week. So it seems to be becoming the prominent one very quickly. It's expected that will become 100% over time. And it's the highest in the Northeast right now. So a little unclear. It seems to be causing less severe disease, but we'll just continue to see what that will look like. I think many people in our population have immunity from Omicron already, so it may not be a huge player. And you might have heard of subvariant XE. The WHO is also now monitoring another Omicron subvariant. It was first identified in the UK in January, and since then it's had about 637 cases. Preliminary research is kind of suggesting this is a recombinant subvariant, so it's actually a hybrid of BA1 and BA2. That usually happens when an individual is infected with both strains at the same time. But it may be 10% more transmissible than BA2. It's playing out in other parts of the world like China and India as well, but we tend to watch the UK because it tends to happen first in the UK and come here. So another variant we're watching. As far as cases for us here, Cass County and most of the state actually remains in the new low risk in those new CDC levels, which is good news. Means citizens are encouraged to stay up to date with their COVID-19 vaccines and get tested with any symptoms. But it's not a current level where we're recommending masks or other public health strategies. And to that end, as of March 9th, masks are required for the public only in our Fargo Cass Public Health Office. We still have them worn in the WIC and clinic service areas, but not in our staffing areas. North Dakota vaccine rates for COVID, it's kind of stagnant. It's probably similar to last time I reported, but total, we're about 58% for one dose of the state, 54 for both doses, and 53% of our citizens have received a booster. We're doing a little better in Cass County, 67% one dose, 62% completed, and then 55% boosted. Our lowest population continues to be that 5 to 11 age range. And COVID vaccines are available by appointment at our Fargo Cass Public Health Immunization Centers. Just a reminder, our hours are 8 to 6, Monday and Wednesday, and then Thursday, 8 to 4. Testing, a quick update. As of the end of March, the North Dakota Department of Health has now taken over our 25th Street location for testing. They are now staffing that and running that. so no longer us directly. They have PCR and Binax Now rapid screenings provided there Monday through Friday, 8 to 5. And we still have testing available by appointment at our main FargoCast public health site. Also, FargoCast is distributing at-home test kits from both our main site and the 25th Street location. Boosters, I just touched on briefly. On March 19th, the FDA authorized a second COVID booster. That's for the mRNA vaccines, Pfizer and Moderna. So that's recommended or authorized for everyone 50 and older and for certain immunocompromised people. It's given 4 months after the first booster. This was an excellent example of scientific debate because not everyone agreed on this decision. Some experts are really expressing that they feel this will help protect older people and higher risk Americans until the fall, when we can likely expect that everyone will need some form of another vaccine. Perhaps there'll be better vaccines at that time. But that is the current recommendation. And then last update about Moderna. Moderna is expected to submit pediatric trial data from ages 2 to 5 to the FDA very soon. I actually thought it might be before this meeting. Their 2-dose mRNA right now is only used for 18 and older, but they submitted clinical trial data for 12 to 17-year-olds quite a while ago, but regulators wanted more information. Moderna is currently used in that 12 to 17 in many other countries, just not here. So there's thought this may come and the data may look better than the Pfizer did in that age group and perhaps could give us a sooner pediatric vaccine, but I'll keep you guys posted.
Thanks, Dr. Newman. I just saw an article come across my email this morning on just some updated numbers on the impact of COVID vaccines. And, since as of March 2022, there's been like 2.2 million lives saved by the COVID vaccine and, 17 million hospitalizations avoided. So obviously there's something that works within the vaccine, and we certainly need to continue to advocate for vaccinations, not just in COVID, which you pointed out. I heard Molly from the State Health Department on the radio this morning talking about the importance of childhood vaccinations and how we're concerned about those rates now. So obviously there's some work to be done across the board. So any other questions? A question? Sure.
Oops, there we go. You said that I don't know if you gave a number or not, but you said that many people had immunity to Omicron when you were talking about these other variants, the BA2 and XE. Now, is there evidence then that if you have Omicron immunity, that you will also be immune to the variants that are coming, or is that too early to say?
I think it's probably too early to say, but given that it's a variant or a slight mutation of the original Omicron variant, we're very hopeful that that immunity would convey. We kind of saw that a little bit with Delta, because since it didn't affect the spike protein as much and the vaccine covered the spike protein, people still had immunity. But I don't want to say anything for certain, but I'm hopeful.
All right. Next up, we have an update on STIs, right?
Okay, so my name is Brent Niesmeyer, and I am the Director of Field Services now, and I serve as the epidemiologist for Cass County during much of the pandemic. And today I'm going to share a little bit about STI rates in Cass County and statewide. Just a little caveat, this data from 2020 should be interpreted, and probably 2021, should be interpreted with caution due to the impact of the COVID pandemic on access to testing, care-related services, and case surveillance activities. The data for 2021 is preliminary and still subject to change. So this is the first slide. This is chlamydia case counts. As you can see, statewide, our chlamydia case counts kind of have remained stable. We bump up and down, but there isn't really too big of an impact. In fact, our numbers from 2021 are more in line with what we saw in 2019, which was prior to the pandemic. So that's probably a better reflection. The dip, like I said at the beginning of the slide, in 2020 probably was due to lack of testing, lack of care, or people just staying home. Case counts for Cass County. In 2020, we saw 893 chlamydia cases, and in 2021, we saw 1,136. Gonorrhea, kind of the opposite. Our case counts actually increased during the pandemic. So you can see in 2020, our cases went up about 140, and then we continued to rise in 2021. Looking at 2022 preliminary data, we probably are going to even be higher than 2021. So we have some work to do as public health and as the state health department on education surrounding gonorrhea and making sure that people have access to testing and treatment. At the end of 2021, the treatment did change for gonorrhea. So now it's a one-time injection versus a dose of azithromycin and the injection. So we are hopeful that more people will get the injection and not, since now they don't have to be dual therapy, then we consider them successfully treated. So hopefully that will work better. Gonorrhea for Cass County, 466 in 2021 and 363 in 2020. So we did see an increase in 2021. Syphilis case counts of all stages. So we do, North Dakota is probably low morbidity. Many states just count primary and secondary syphilis, which is the more infectious stages or stages that mean that you were infected within the last year. We did increase in 2021 statewide to 105. Syphilis prior to probably 2010, many providers had never seen syphilis in their emergency rooms or providers' offices, and now providers are probably seeing it more or less all the time, whether it's titer management or a new infection. We still have some education to do on that as well, because I've seen case notes of people who have obvious secondary syphilis or primary syphilis signs and symptoms, and they're referred to another provider or referred to dermatology, and whereas it could have been diagnosed with a simple blood test at that time, whereas making them wait a week or two is where they could still spread it is probably not the best practice.
Can I ask a question here? So I'm assuming you have data pre-2016.
Yeah, we had data way
This
back.
trend is concerning. Does it go back a ways?
Yeah, so even prior to 2016, our case counts were far lower. So our syphilis has increased dramatically, and we are seeing that nationwide too, with syphilis being the highest rates of increase. The numbers are still low, but if you look back at gonorrhea, 20, 30 years ago, those numbers were similar to what some areas are seeing for syphilis. So that is why we are trying to work and implore providers, when someone comes in for STI screening, to take that blood draw, test them for syphilis, whereas gonorrhea or chlamydia is generally a urine screen unless you're doing 3-site testing. That's probably something that we need to work on as well, and we don't have access to rapid syphilis testing, so it is actually a blood draw, whereas like if someone comes to Portal Cast for a HIV test, you're getting your results in 15 minutes. We can go out in the community with these rapid tests. We can go to the Gladys Ray shelter. We can go to the women's shelter. We can set up booths in a park and do rapid HIV testing, but we don't have the same for syphilis. They have to actually have a phlebotomy or a blood draw tube.
Just one more comment on this. I think if we can see it on even like a per thousand basis, so we can compare it to other states, because I'm not sure if we're seeing similar
Yep,
patterns across, but knowing that our communities are growing too, I think that would be a good.
And I will share, the CDC just released their 2020, and I'll make sure to get that to you all. It's still preliminary. When that does go live, where North Dakota sits nationwide. I know that we are above or right around that. I think we're above the national average for syphilis.
Perfect.
What is concerning as well, so you look at our numbers, 105 in 2021. our neighbor to the south, South Dakota, is undergoing a huge syphilis outbreak, and I believe in 2021, South Dakota is going to report over 1,000 syphilis cases. And with that, we will go into future slides and what the concerns of that are. Cass County makes up about a quarter of our syphilis cases. Congenital syphilis is the main concern, is what we're concerned about. Prior to 2020, North Dakota hadn't seen a congenital syphilis case. In 2020, we saw 3. In 2021, we saw 2. Unfortunately, North Dakota does not have a law requiring screening for syphilis during any point during pregnancy. It's one of the few. So it is something to consider. Some states have screen at the first trimester. Some states have laws that require screening at first trimester, early in the third trimester, and at delivery. Unfortunately, North Dakota does not have anything on the books. It is mostly a part of every prenatal panel, but it is not required. Congenital syphilis, 2020, 9 known pregnancies in 2020. Three of those resulted in congenital cases. 2 screened negative at the first prenatal visit and tested positive after delivery due to symptoms. So missed opportunities, and why 3 screens during pregnancy is super important. With congenital syphilis, it can lead to birth defects. It can lead to death of an infant. It can lead to delays. So it is not something that is to be taken lightly. And then one of those received no prenatal care, which we were unable to avert that. But if we increased prenatal care efforts, maybe we could have gotten her in. 2021, kind of the same situation. 1 tested late in prenatal care. In order for syphilis treatment to work, you have to have 4 weeks post-treatment. And I think she was tested, like 2 weeks before delivery. So we were unable to provide, we still would have had to count that as a congenital syphilis case, and then 1 received no care. Incident HIV rates, these are new HIV infections in North Dakota. 2021, we saw 37 statewide. Cass County, we saw 18. And then North Dakota did report a congenital HIV case in 2021. So this individual, there was a negative screen at the first prenatal visit, tested positive after delivery. This individual did test positive twice during the course of her pregnancy for other STIs, and they did not redo HIV test at any point. She was later tested in the ER. We went back to our records and saw that she was pregnant during one of her gonorrhea visits, and then later we tested the baby. Baby's in care, baby's doing well, but it's just an unfortunate outcome in that situation. Hepatitis C, numbers are dropping, but we did have a change in case definition, so probably more in line with what we are doing. Cass County.
May I be heard? Cass County has approximately 24% of the population of the state of North Dakota. When I look quickly at your charts, it appears that your statistics are roughly about 24% of those of the state. Is that your analysis as well?
Cass County probably does have probably about 25, 30%. Some of our conditions a little bit more. We do have better access to care and access to testing in Cass County than we do in some of our rural areas. But we do, you are correct, is that we probably do make up about 25%. But that being said, some of our rural counties, they may have to drive 100 miles to have an appointment. So if we can drive 2 minutes to an appointment, we should be able to have more mitigation or more methods in order to stop that transmission here locally.
Thank you.
Yep, no, good question. Hepatitis C, hepatitis B, numbers have also dropped. That could also be due to many of our hepatitis B cases are imported into North Dakota. There are people who not necessarily were born in North Dakota, but now live here. And in 2021, we did see a decline in people immigrating to North Dakota. That being said, Cass County is county in which most people move to or migrate to. So we do have about 2/3 or more of our hepatitis B cases in North Dakota within Cass County. And if you want more information on data, that's where you can find it. Tried to go quick, so thank you as respect for your time.
Thank you. Do you have any questions? Okay.
Thanks, Brenton. So I'm assuming that part of your work is breaking down the data by demographics to focus education and resources. Yes. Have you identified any groups? So if it's college students versus adults, you reach them differently. Have you identified any groups, especially with the syphilis, that perhaps we haven't focused education and resources on?
So we are seeing increase in syphilis rates, especially of our persons of color or persons, native to North Dakota population, and also among our MSM population, or men who have sex with men. So we do focus and do our advertising on applications that people use, but a lot of it is just anonymous. We aren't able to get partners just because they might not know who their partners are. So we're just trying to be proactive and meet people where they're at, and whether it's testing people through getting people tested or linked to resources through applications people may use is kind of our primary efforts right now.
Thank you.
Great question. Okay. Excellent. Thank you. All right. Oh, Dr. Newman, go ahead.
Can I just make a comment? Sorry. This is something I teach in our public health course at NDSU. So this is not unique to North Dakota, particularly the chlamydia and gonorrhea statistics and syphilis, actually. It's nationwide. It's actually worldwide. But the numbers in America as a whole are pretty astounding over the last 5 to 6 years. And part of this has prompted us to change the way we're screening people. So now we're screening in younger ages, in adolescents and things like this. Also, I believe part of it was due to some of the resistant organisms we were seeing. And so now our treatment guidelines for both were just changed this past summer. And we just updated that at Fargo Cass as well. So I hope to see with some of those changes, these rates start to decline. But I think it's prompting us to change the way we're doing things. So.
Great. Excellent. Do you want to give, Larry, do you want to go next? Or do you want to switch around the agenda? We're going a little bit over time. I don't know if you want to defer any parts or if you want to try and get through it. It's up to you.
Yeah, I guess it's up to you guys. I don't know that it's a long update.
No,
Okay.
I'll keep
Okay.
it brief.
Sounds good. Go ahead, Larry.
Okay. Good afternoon, Board of Health. My name's Larry Annenson. I'm the clinic director at Fargo Cass Public Health. And I just wanted to give you a very brief summary of our site visit. As you're aware, we are a Title 10 reproductive health, Title 10 clinic. I've been doing reproductive health services since 1972. The main reason of our site visit is just to ensure that we are meeting the goals and objectives of Title 10, and we're providing services such as wellness exams, life-saving cancer screenings, birth control, contraceptive education, testing and treatment of STDs. Most because of COVID, much of the actual site visit this year was done virtually. However, we did have a team from the North Dakota Department of Health come on site and interact with our staff, review our policies, were witness of some of the care that we provided to our clients, and it was a real true team effort. Took a great deal of time to prepare throughout the pandemic, but again, our staff did a wonderful job. With our site visit, there's 3 main components. They focused on the financial aspect of our clinic administration as well as client services. And there was many positives that they identified. I'll just go over a few. They identified the friendly staff and how staff were eager to do things the right way. And as we've talked even today during the meeting, things do change, best practices change, and we're always eager to learn when things change, just so we can update our policies, our standing orders, and so on, so we can continue to provide that care. They identified the staff flexibility, the warm hospitality. A strength they identified was our charting and documentation, the medical providers' compassion for the clients they serve, and then the client-centered care that was provided that they witnessed that day. Some of the areas that they identified for improvement, our clinic can get quite busy, so they identified our lobby and our main front desk area and suggested that we look at how it's configured just to ensure privacy of our clients, but then at the same time making sure that our staff can work efficiently. We're going to look at some of our billing practices and how we collect our fees, as well as the data. As you know, data helps dictate programming and needs and so on. There's 10 other family planning clinics in the state of North Dakota, and it's important that our data that we into our software, data collecting software, is consistent and accurate. So we're looking at that process as well, so we are consistent throughout the state of North Dakota. And then how we're charting in the medical records to avoid double entries, and then to ensure that all of the care that we do provide our clients is accurately documented. And in closing, I just would like to, again, mention that it truly was a team effort. I am very proud of our staff and all the work that they did to prepare for the site visit and the care that they provide our clients day in and day out. And I do want to acknowledge the Board of Health for the continued support of our Title X family planning program at Fargo-Cass Public Health. I'm available for any questions anybody may have.
Thanks, Larry. Site visits can be nerve-wracking, so sounds like you passed with flying colors.
I would just say congratulations to you and the team.
Thank
I
you.
know how stressful those are.
Okay. Melissa, some highlights from the budget.
Let me turn my mic on. There we go. So, as previously mentioned, the budget had to be done a lot sooner this year than last. And last year was sooner than all years prior, so we're on a roll. Anyway, so I'm gonna go through the revenue sheets. I think you got new ones today, revenue and maybe just expenses. Today I had found that some of the lines were in the wrong places, so I corrected those, but I'm gonna go through the revenue sheet first, and our first section there is called grants. That is our federal funding that flows through the state. Funding comes from either the Health and Human Services or the Department of Commerce. That makes up all those line items. Two significant changes are in Ryan White and MCH. Ryan White funding has increased based on the numbers we see. MCH decreased because funding changed from competitive to all requests across the state being funded. The last four items under the grants is all related to COVID. The CARES funding actually ended last year. The next line you see there is the emergency solution grants. That's for harm reduction. And that funding also ends this year. The ARP funding will be done in early '23, so revenue for that line will depend on what happens again this fall and into next spring. The next section you see is state grants, and that's mostly the tobacco, mobile outreach, and opioid funding seems to remain stable for another year. The other changes you see are just based on history. The next line is state aid. We haven't seen any changes on that, haven't heard anything, so we'll see if that changes going forward. Under the next section, it's local funding. The thing I want to draw attention to is a United Way funding that is done this year. Under Fargo Public Schools, we're in this year 2 of a 3-year contract, so those numbers we know what they are this year and going into next year. We increased the donation line under Gladys Ray Shelter because they've been doing a fabulous job on Giving Hearts Day. Let's see, down all the way, I'm gonna skip right on down to Cass County. We will be increasing that budget. Mostly that's due to salary and benefits. Turnover in staff there increased the benefits quite a bit. The new staff coming on are taking more than the old staff that were leaving, so it makes a difference. And the correctional health increase is more due to operational, as we found out this last year, in supplies and travel. Overall, our budget is going to be increasing we're requesting more money for staff for education. So on to the expenses side. Our operational budget increase is for $97,000. Again, at Ryan White, we received an increase in that funding, thus increasing the help we can provide to those clients. We have increases in cleaning costs and utilities for our buildings across the board. We requested increase in education for all staff, so that shows up in travel, seminar, and conference line items. We moved our building repair budget, that you see there's a negative 17,000 because that all got moved to the buildings and grounds budget for that department as an effort to, for that department to see what the costs are for city buildings and not spread it out over each department. And then the last thing we decreased was paying off a lease of an SUV, so that was removed from the budget also. So that was very quick, but do you have any questions?
Madam Chairman, we talked earlier about the fact that the city of Fargo required an April 1 submission of your budget,
Yes.
but you also have a budget submission to the county, is that correct?
Yeah, that is still coming, yes.
But it's included in the Fargo budget?
It is, what I have done is gone through the budget and determined what our request will be. If it gets changed at Cass County, then we'll request the city of Fargo to adjust their budget.
Thank you. So that everyone knows and understands, the county pays for rural health services throughout Cass County. And it's projected for 2023 at close to $1 million. In addition, that doesn't seem to be a problem for the county, but the one thing that is the contract with the county to provide health services to the inmates at the jail. Now, in the past, it's my understanding that you've had difficulty recruiting additional staff to provide that service. Is that still true, or are you making progress in that regard?
I think we've made some really good progress lately. We do have a new nursing supervisor there. So I think they're working a lot on efficiency. And also, we have had some turnover in staff, but I think we have one open LPN position right now, but we have interviewed and are hoping to be able to offer, and then that we would be fully staffed.
So that everybody understands, that cost is approaching $700,000 a year. It may be less than that for 2023, but we've had some real difficulties with COVID and rapid testing at the jail and placing inmates in the single cells instead of doubles. It's been difficult for the jail staff to function, given the what I think is the shortness of staff, at least in past. And hopefully we're going to address that and take care of it. If there is a need, I should think you would increase that figure in your request to the county for budget purposes so that we can say yes, but provided you provide additional staff to provide that service.
Yeah, we have had conversations with the county. You know, Fargo Cass is probably one of the only agencies across the state that kind of provides such a robust program for correctional health through public health. So we probably are at capacity with what we can provide for staffing. And we've had those talks with the county. So if there is a need to grow beyond where we are right now, we have said that we don't know that we can meet that metric as local public health, and they may have to seek another staffing agency to help provide further needs if they really if they wanted to go to 24/7 or something like that for nursing. We don't have the capacity within local public health to cover that.
Would an increase in that contractual amount help?
It really has to do with what we can provide as a staff. And when you get into, 24/7 coverage and all of that, that's kind of going outside of public health and really beyond the initial intent of what when we first came into that agreement for correctional health. So I think we can certainly have discussions, but we'll have to make sure that we as an agency can provide the needed resources for our own programming as well as what we would anticipate from the jail and make decisions going forward.
Thank you.
Madam Chair, if I could ask a question. The contract with the county, or I'm assuming it's a contractual relationship, is that an annual contract? And should these conversations be rolled into that if they're seeing a need for 24-hour?
Yeah, so we redid the contract in 2018 or 19, I believe, for Cass County. And it renews unless there is a significant change based on either party. And so it's pretty up to date right now. And then we just address, the meetings we've had have been with Sheriff Johnner and Captain Frobig and our staff and Suzanne, who supervises the jail. We've had those discussions as well with city administration here and what the limitations of public health are.
So I have two hopefully quick questions. Nurse Family Partnership funding and the United Way ending, is that going to impact that program and the work that they do?
It shouldn't. We knew that was coming.
Okay.
And so we've been planning for that. United Way has been great to support us, but they are not a long-term funding solution. We do have a potential opportunity with the health department at the state to have some preventative funding that may help with our Nurse Family Partnership program. So we're waiting to hear on that. But we will not be decreasing any services at this time.
Okay, that's good to hear. And then the MCH line item, just maybe a little bit expand on that. I mean, it's pretty low compared to what it has been, so.
Yeah, and MCH has gone through significant changes at the state. So it used to be a competitive grant process, and there was 3 or 4 entities that would get, 100 and some thousand for MCH services. And then they decided to change their process at the state and just offer it to all local public health, which then decreased it to $15,000. So, given our county size, it's not very equitable for us. So we just had to, it again isn't gonna, we did some streamlining in our health promotion division when we had a retirement. And we really, for our MCH program that's in nursing, we kind of do that alongside of the Nurse Family Partnership program. So it's not going to impact current services. It's just shifting funding.
Okay. Other questions? Okay. I don't see anybody for public comment. So next meeting then is August 19th. It will be warmer. So that's good. All right. Thanks, everyone.